Hello and good day everyone. Today I'm going to discuss about platelet defects, hemophilias, and the von Willebrand's disease. But before we get into that, let's review first what platelets are. What are platelets? These are tiny cell fragments that float around in our blood. When a blood vessel is damaged, collagen is exposed. This collagen exposure attracts platelets to the injured area. The platelets then stick together to form a plug. They've quickly built a barrier that stops us from losing too much blood. However, this platelet plug isn't that strong, so it needs to be made stronger. A protein called fibrin does exactly that. In our blood, there are soluble fibrinogen proteins. At a wound, these soluble fibrinogen proteins are exposed to outside chemicals that aren't normally found in blood vessels. Like with the collagen in platelets, this exposure causes the fibrinogen proteins to turn into sticky fibrin fibers. The fibrin fibers form a mesh, holding all the platelets together and making a much stronger clot. More platelets, red blood cells, and other components in our blood all get stuck to the mesh, making it even stronger. This clot stops more blood escaping the body and also prevents pathogens from entering our body from the outside. The clot develops into a scab which protects the wound as it heals, and new layers of skin form underneath. Now, let us discuss platelet defects. Platelet defects can either be quantitative or qualitative in nature. Quantitative platelet defects are relatively common, those of which include thrombocytopenia. But qualitative defects can also occur. With qualitative defects, the number of platelets may be normal, but the platelets do not function normally. In the past, bleeding time was most commonly used to evaluate platelet function. Now, a platelet function analyzer is often used. This method is particularly valuable for rapid and simple screening. Now, substances like aspirin may induce a functional platelet disorder. Even small amounts of aspirin reduce normal platelet aggregation, and the prolonged bleeding time lasts for several days after aspirin ingestion. As with NSAIDs, it can also inhibit platelet function, but the effect is not as prolonged as with aspirin, which takes about 5 days versus 7 to 10 days. Now, other causes of platelet dysfunction include end-stage renal disease, MDS or myelodysplastic syndromes, multiple myeloma, cardiopulmonary bypass, and herbs and other medications. Now for the pathogenesis of platelet defects. Platelets are produced in the bone marrow from megakaryocytes, in which production is increased up to 8-fold. And because of this, 1/3 of platelets are sequestered in the spleen. Now, in the event of hemostasis, platelets rush to the site of injury and acts as the initial hemostatic plug. An example of a platelet defect is thrombocytopenia or low platelet count. Because of the decreased platelet production in the bone marrow, there is a sequestration of platelets in the spleen. What happens is there will be a peripheral platelet destruction by antibodies and consumption in the thrombi. In turn, there's dilution from fluid resuscitation or massive transfusion. Hence, insufficient platelets to form clots leads to prolonged or easy bleeding. The clinical manifestations. Bleeding may be mild or severe. Its extent is not necessarily correlated with the platelet count or with tests that measure coagulation. Now, ecchymoses are common, particularly on the extremities, and patients with platelet dysfunction may be at risk for significant bleeding after trauma or invasive procedures. Now, for diagnostic procedures. First, we have bleeding time and tests for factor deficiencies. The bleeding time has traditionally been used as a screening test for the presence of a platelet functional defect. If performed carefully in a well-standardized manner, the bleeding time correlates with both platelet number and function. Complete blood count. The CBC can provide evidence of hematopoietic disease, especially a myeloproliferative disorder where high numbers of circulating platelets are associated with abnormal function. And we have measurements of platelet activation and aggregation. Direct measurements of platelet activation or aggregation are possible using an aggregometer or flow cytometer. Treatment modalities. First, there is the prevention of intracranial or serious internal hemorrhage. We also have corticosteroid therapy. Treatment with corticosteroids may not only reduce the rate of platelet destruction, but may also rapidly alter endothelial cell integrity to facilitate primary hemostasis and to reduce bleeding and bruising. Prophylaxis and treatment of bleeding in patients with platelet disorders. We also have systemic antifibrinolytic therapy. Antifibrinolytic agents such as tranexamic acid are effective in the management of bleeding in patients with thrombocytopenia. And lastly, we have local measures such as the use of nose pads or fibrin sealants. Local bleeding such as nose or gum bleeding in patients with platelet disorders may usually be stopped with conservative local measures, including nose pads or fibrin sealants, which contain fibrinogen, thrombin, factor VIII, and aproteinin or fibrin-coated collagen fleece. Surgical management. First, we have splenectomy. Splenectomy is effective because it removes the major site of platelet destruction and the major source of antiplatelet antibody synthesis. Even if complete remission is not achieved, the platelet count will be higher after splenectomy. We also have bone marrow transplant. Bone marrow examination is necessary in patients whose condition has an atypical course, have splenomegaly, or will undergo splenectomy, and in patients over 60 years, as thrombocytopenia may be the initial manifestation of myelodysplastic syndrome. The nursing diagnoses for platelet defects are as follows: risk for bleeding related to decreased platelet count, risk for injury related to abnormal blood profile, risk for ineffective protection related to altered kinesthetic perception, and risk for infection related to suppression of the immune system by steroids. The prognosis. Approximately 60 to 90% of adults with platelet defects respond with an increased platelet count after treatment with prednisone and 4-RHIG or 4-IG. Of those adults who do not maintain an increased platelet count and who require splenectomy, approximately 2/3 have a sustained response and 10 to 15% have a partial response. Now, let's move on to hemophilias. Hemophilia is a relatively rare disease in which blood doesn't clot normally because it lacks sufficient blood clotting proteins or clotting factors. There are two inherited disorders. They can either be hemophilia A and hemophilia B. They are clinically indistinguishable, although they can be distinguished by laboratory tests. Hemophilia A occurs in 1 of every 5,000 births, 3 times more common than hemophilia B. Hemophilia A is caused by a genetic defect that results in deficient or defective factor VIII, whereas hemophilia B is also called Christmas disease. It stems from a genetic defect that causes deficient or defective factor IX. Now, both types of hemophilia are inherited as X-linked traits, so almost all affected people are males, although females can be carriers, but are almost always asymptomatic. Hemophilia is recognized in early childhood, usually in the toddler age group. However, patients with mild hemophilia may not be diagnosed until they experience severe trauma or surgery. Now for the pathogenesis. The genetic defect on the X chromosome affecting the factor VIII or factor IX gene causes deficiency of functional factor VIII for hemophilia A or factor IX hemophilia B in the blood. This causes factor VIII or IX deficiency shows intrinsic clotting pathway, leading to increase in PTT. And factor VIII or IX deficiency that is not part of the extrinsic clotting pathway would lead to normal PT. Now, this deficiency of functional factors creates an insufficient clotting action when faced with a bleeding challenge. This leads to uncontrolled bleeding that occurs across the entire body, leading eventually to hemarthrosis or bleeding in joints, intramuscular hematoma, dental bleeds, intracranial hemorrhage, and GI or GU bleeds. In severe patients, repeated joint bleeds are common. This recurrent bleeding into joints damages the cartilage, eventually leading to chronic hemophilia arthropathies. Now, the clinical manifestations. Hemophilia is manifested by hemorrhages into various parts of the body. These hemorrhages can be severe and can occur even after minimal trauma. The frequency and severity of the bleeding depend on the degree of factor deficiency as well as the intensity of the precipitating trauma. Now for diagnostic procedures. This includes a complete blood count, activated partial thromboplastin time or APTT test, prothrombin time or PT test, fibrinogen test, and clotting factor tests. Now for the nursing management. Most patients with hemophilia are diagnosed as children. They often require assistance in coping with the condition because it is chronic, places restriction on their lives, and is an inherited disorder that can be passed to future generations. Now, what we can do is encourage to be self-sufficient and to maintain independence by preventing necessary trauma that can cause acute bleeding episodes and temporarily interfere with normal activities. Now, patients with mild factor deficiency may not be diagnosed until adulthood if they do not experience significant trauma or surgery as children. Another management includes extensive teaching about activity restrictions and self-care measures to diminish the chance of hemorrhage and complications of bleeding. Another is to encourage safety at home and in the workplace. Patients with hemophilia are instructed to avoid any agents that interfere with platelet aggregation, such as aspirin, NSAIDs, herbs, nutritional supplements, and alcohol. This restriction also applies to over-the-counter medications, such as cold remedies. Dental hygiene is very important as a preventive measure because dental extractions are hazardous. And during hemorrhagic episodes, the extent of bleeding must be assessed carefully. And genetic testing and counseling should be provided to female carriers so that they can make informed decisions regarding having children and managing pregnancy. Now for the medical management. Patients are given concentrates when they are actively bleeding or as a preventive measure before traumatic procedures. Examples include lumbar puncture, dental extraction, and surgery. Now, it is crucial to initiate treatment as soon as possible so that bleeding complications can be avoided. Now, a study shows that between 15 and 30% of patients with hemophilia A and between 2% and 5% of patients with hemophilia B develop antibodies to factor concentrates. Now, patients may require plasmapheresis or concurrent immunosuppressive therapy, particularly in the setting of significant bleeding. Now, others include activated prothrombin complex concentrates can also be used to control bleeding. Also, patients with severe factor deficiency should be screened for antibodies, particularly before major surgery. And aminocaproic acid inhibits fibrinolysis and therefore stabilizes the clot. It is very effective as an adjunctive measure after oral surgery and in treating mucosal bleeding. Another agent, which is desmopressin or DDAVP, includes a significant but transient rise in factor levels. The mechanism for this response is unknown. Now, in patients with mild forms of hemophilia A, desmopressin is extremely useful, significantly reducing the amount of blood products required. Surgical management. Hemophilia can be treated by replacing missing blood clotting factors. This is called clotting factor replacement therapy. Clotting factors are replaced by injecting or infusing a clotting factor concentrate into a vein. Infusions of clotting factors help blood to clot normally. The plasma factor concentrate is made from human plasma. The plasma is processed to separate the clotting factors from the other parts of the plasma. This creates the clotting factor concentrate. The concentrate is processed to kill any viruses that might have been in the plasma. Now for the nursing diagnoses of hemophilia. First is acute pain related to hemarthrosis, impaired physical mobility related to pain and discomfort with the onset of bleeding episodes, compromised family coping related to prolonged disease or disability progression that exhausts the physical and emotional supportive capacity of caretakers, risk for bleeding related to decreased concentration of clotting factors circulating in the body, and risk for injury related to decreased clotting factor. Prognosis. With proper education and treatment, patients with hemophilia can live full and productive lives. Prophylaxis and early treatment with factor VIII concentrate that is safe from viral contamination have drastically improved the prognosis of patients with severe hemophilia. Nevertheless, approximately 1/4 of patients with severe hemophilia, aged 6 to 18 years, have below normal motor skills and academic performance and have more emotional and behavioral problems than others. And for the last topic on our list, we have von Willebrand's disease. Now, von Willebrand's disease is a common bleeding disorder affecting males and females equally. It is usually inherited as a dominant trait. It is caused by a deficiency of VWF, which is necessary for platelet adhesion at the site of the vascular injury. Now, there are 3 types of von Willebrand's disease. Type 1 is the most common. It is characterized by decreases in structurally normal VWF. Type 2 shows variable qualitative defects based on the specific VWF subtype involved. As for type 3, which is very rare and is less than 5% of cases, and is characterized by a severe VWF deficiency as well as significant deficiency of factor VIII. Pathogenesis. Von Willebrand's disease may either be acquired or inherited. For acquired, there is a presence of antibodies to the VWF. These antibodies bind and inactivate the existing VWF. For inherited, there's the type 1, type 2, and type 3, as discussed earlier. All these cause reduced VWF quantity and/or function. This often leads to less VWF available to bind to damaged vessel collagen to anchor platelet, reduced VWF antigen assay, and reduced plasma factor VIII. This causes impaired platelet plug formation, leading to prolonged bleeding or closure time, as well as epistaxis, bleeding from mucosal surfaces, skin bleeding, easy bruising, and spontaneous hematomas. The reduced plasma factor VIII causes impaired intrinsic pathway, which eventually leads to prolonged partial thromboplastin time, or PTTT. Now, the clinical manifestations of this disease. Bleeding tends to be mucosal. Patients commonly have recurrent nosebleeds, easy bruising, heavy menses, prolonged bleeding from cuts, and postoperative bleeding. Massive soft tissue or joint hemorrhages are not often seen unless the patient has severe type 3 von Willebrand's disease. As the laboratory values fluctuate, so does bleeding. Now, for the assessment and diagnostic findings of von Willebrand's disease, laboratory tests results show a normal platelet count but a prolonged bleeding time and a slightly prolonged APTT. More important tests include the ristocetin cofactor or VWF collagen binding assay, which measures VWF activity. Other tests include VWF antigen, factor VIII, and for patients with suspected type 2 defects, VWF multimers. Now for the medical management. The goal of treatment is to replace the deficient protein, for example, the VWF or factor VIII, at the time of spontaneous bleeding or prior to an invasive procedure. Now, desmopressin or DDAVP is a synthetic vasopressin analog, which can be used to prevent bleeding associated with dental or surgical procedures or to manage mild bleeding after surgery in those individuals with mild VWD. DDAVP provides a transient increase in factor VIII coagulant activity and may also correct bleeding time. It can be administered as an IV infusion or intranasally. With major surgery or invasive procedures, IV administration is preferable. DDAVP is contraindicated in patients with unstable coronary artery disease because it can include platelet aggregation and cause MI. Now, replacement products include Hemate P and Alphanate, which are commercial concentrates of VWF and factor VIII. Antibody formation to these products usually occurs only in patients with type 3 VWD after administration of high doses. Other agents such as aminocaproic acid and estrogen-progesterone compounds may be effective in reducing bleeding. And aspirin should also be avoided. Now for the nursing diagnoses. This includes impaired physical mobility related to pain and discomfort with the onset of bleeding episodes, risk for bleeding related to decreased concentration of clotting factors circulating in the body, and risk for injury related to decreased clotting factor. The prognosis. For most affected individuals, von Willebrand's disease is a mild, manageable bleeding disorder in which clinically severe hemorrhage manifests only in the face of trauma or invasive procedure. However, significant variability of symptomatology exists among family members. And that is all for today. Thank you for listening.